The screening issue is a very intriguing one. Should we be doing screening tests of large, unselected segments of the population? To do that, you have to have the perfect test. And are we talking about screening for the presence of atherosclerosis, or are we talking about screening not only for atherosclerosis, but for the patients who may be at risk for plaque rupture, the patients who may have vulnerable plaques? I don't think we have all the answers there. We need to, first of all, evaluate what we know already from this screening for atherosclerosis, where we know you pick up a lot of patients, but the predictive accuracy of which of those patients is going to wind up having a stroke or a myocardial infarction is a little bit unclear. My perception is that there's probably a segment of the population that represents kind of an intermediate risk, where our screening test may be most important. You have a patient who has a no family history, low cholesterol, low CRP. I'm not sure you need to do any fancy imaging tests in that patient. Patient with a positive family history, high cholesterol, hypertension, smoking, that patient, is already at incredibly high risk. That patient just needs to have a very aggressive risk factor modification. Now, in the intermediate zone, where you have indeterminate risk, or maybe a patient who has already had a cardiac event, maybe had a stent at age 45 without having a whole lot of additional risk factors, then the question is, do we need to develop the correct tests for these individuals, or do we just give them the most aggressive risk factor modification we can think of? Lowering their LDL cholesterol down to 75, keeping their blood pressure under control, really aggressive with diet and exercise. I'm not sure every person in the USA should be receiving a statin drug, but if I had a patient with a lot of risk factors, maybe a little calcium in the arteries, then I treat that patient as if the patient's already had a myocardial infarction. I give that patient all of the secondary prevention strategies I would muster for a patient who's had a previous myocardial infarction, because of the potential that patient may have a plaque vulnerability. Now, if we could develop a better non-invasive diagnostic test to actually identify vulnerable plaque, that could shift the equation. Then perhaps those patients could be screened to identify which of those patients actually will benefit from an expensive medication-driven kind of risk factor modification that we don't want to give to the entire population. So I'm certainly looking for such a test, and I support all the research that's going on in that area. I don't believe we're there yet. I would hope that with some of the more sophisticated CT and MRI methods that are being developed, plaque characterization tests, maybe thermography, other forms of testing, maybe something with future research and more experience that could help us there. The other issue is whether the risk factors for atherosclerosis are the same risk factors for plaque vulnerability. And that's a great question. I mean, is it a random event that once you have atherosclerosis, it's a roll of the dice, and you will or you won't develop plaque rupture based upon chance? Or are there other factors that would identify those patients who have stable versus potentially unstable plaque? I don't know the answer to that question. For example, CRP. CRP clearly can identify patients at risk for future events. They've got a lot of inflammation, plaques become vulnerable and may rupture. But CRP, in my reading of the literature, also identifies patients who may develop atherosclerosis. Some of the more recent CRP studies comparing CRP with calcium scores, show that as calcium scores progress, they're progressing more in the patients who have the elevated CRP. Is that because they have more vulnerable plaques, or is it just because they are laying down more plaque, vulnerable or otherwise? I interpret the CRP information and maybe other measures that may come down the pike in the area of inflammation and other areas that perhaps there's a additional risk factor beyond atherosclerosis that we need to be looking for. The way I manage my patients is with CRP and cholesterol. I mean, I take the CRP as a very important additional risk factor that I think does highlight patients at risk for plaque vulnerability, and independent of the cholesterol, I would treat that patient with a statin, aspirin, ACE inhibitor, and so forth.